Good morning, everybody. My name is Arkati Soni, and I'm a PGY1 internal medicine resident at St. Vincent Hospital, Worcester, Massachusetts. And today I'll be discussing with you a topic which, if dwelled further into, could not only avoid overtreatment but also the consequent adverse effects on patients and the cost burden on a hospital. Our study was conducted with the primary aim to distinguish between stroke mimics and true strokes based on clinical features and imaging. So, what is stroke? The World Health Organization defines stroke as a rapidly developing clinical signs of focal or global disturbance in cerebral function lasting more than 24 hours or leading to death with no apparent cause other than a vascular origin. However, in reality, there are multiple conditions that present with neurological deficits mimicking a stroke, the most common of which being seizures, conversion disorder, encephalopathy, brain tumors, and migraines. And because of the time sensitive nature for therapy in strokes, it is not uncommon for strokes to be overdiagnosed and treated with tissue plasminogen activator therapy or TPA. So, we at St. Vincent conducted a retrospective case control study where we identified 116 patients who had received TPA therapy for treatment of an acute thromboembolic stroke. Out of these, 79 patients who had a normal computed tomography angiography or CTA were included for further analysis. They were divided into two groups. Group 1 with the cases of the stroke mimics, and Group 2 with the control of the true stroke patients based on their magnetic resonance imaging or MRI findings of the brain. Their individual medical records were reviewed to check for a history of seizure, stroke, hypertension, hypolipidemia, diabetes, the National Institute of Health Stroke Scale score, hemorrhagic conversion post TPA, encephalopathy, migraine, and conversion disorder. It was found that out of the 79 patients, 46 were stroke mimics. Table 1 shows the distribution of study subjects based on history, and findings reveal that after a Fisher's exact and chi-square test, there was a statistically significant difference between the two groups for prior stroke, history of seizures, depression, migraine, conversion disorder, and post-stroke recrudescence exacerbated by acute encephalopathy. Table 2 shows that there is no statistically significant difference between the groups with regards to age and the NIHS score, based on an independent t-test. And Table 3 shows a logistic regression analysis performed using the statistically significant variables from Table 1. And it proves that patients that present with acute migraine episodes and conversion disorders have a statistically significant positive association in being a stroke mimic. It is true that lab investigations and brain imaging can refine diagnosis, but clinical assessment remains vital because it is the first step in the diagnostic pathway and often directs the speed at which more complex procedures are undertaken. Like I mentioned before, multiple conditions can masquerade as stroke and have been mentioned in literature over the years by the likes of Dr. Libman, Dr. O'Connor, and many more. In most of these studies, the most common stroke mimics include brain tumors, toxic or metabolic disorders like hypoglycemia, hyponatremia, thyroid storm, migraines, and conversion disorder. And although such conditions physiologically differ from brain strokes, the similarity of symptoms makes diagnosis difficult. But more often than not, stroke mimics have less clearly defined neurological symptoms, and they typically do not adhere to the well-defined stroke syndromes. The suddenness at onset is not always evident. Fluctuations in severity are common, and systemic signs, including drowsiness, confusion, headache, agitation, and fever, are much more common in stroke mimics. For these patients, the treatment depends on the treatment of the underlying condition. And while it is not easy to confirm the diagnosis of stroke in the acuity of an emergency department or medical floors, standard of care requires patients to undergo a CT stroke protocol before TP administration. Aura before onset, headache, or a prior history of depression in the setting of a normal CTA might actually point away from a stroke. Based on our findings, it could be postulated that paying more attention to a patient's history and clinical examination as the first step can aid in the accurate diagnosis of stroke mimics and avoid overtreatment. Thank you everyone for joining in, and I hope you have a great day ahead.